information on prevention, tools for a healthy lifestyle. Make little changes to be the best you. It's all here. A podcast empowering, informing, and motivating Bermuda to live well. Bermuda Health-Abets. Everything from A to Z on healthy living. Brought to you by the Health Promotion and Wellness Office of the Department of Health in collaboration with local health partners.
Welcome to an episode of Bermuda Health-Abets. This is a podcast where we discuss everything from A to Z on healthy living, with the mission of empowering, informing, and motivating Bermuda's residents. Hi, I'm Marie Beecher, host today. I've worked for 20 years as the Healthy Schools Coordinator for the Department of Health. I work closely with schools, the Department of Education, other government departments, and most community health partners that have programs and activities in schools. Today, our topic is Breathing Easier, Understanding and Managing COPD. Our guest today is Dr. Kimberly Foley. Welcome, Dr. Foley.
Hi, Miss Marie. Nice to meet you today. Nice to be here.
Lovely. Can you please tell our listeners something about yourself and your role?
So I'm a Bermudian pulmonologist, which is a lung specialist. My role here in Bermuda is to help us have better lungs and better lung health. I came back to Bermuda in 2019 after finishing all of my extensive studying. I'm board certified in internal medicine, pulmonology, and critical care. I left Bermuda when I was 18, and now I'm in my 40s, so I'm glad to be back, but it's been a long journey.
What made you choose this field?
Well, initially I wanted to do anesthesia, but then I switched over to pulmonology, mainly because I'm interested in critical care. So I like the intensity of the ICU. I don't practice it here in Bermuda, but I do have my licenses in New York and Pennsylvania and Massachusetts, as well as Bermuda. So, but I like the excitement of the ICU. So to manage the ventilators and things like that, you have to be really keen and an expert in the lungs.
Wow. Well, we're lucky to have you here in Bermuda,
Yes,
Dr.
thank
Foley.
you, thank you.
So please tell our listeners, what is COPD and how does it affect your day-to-day life?
Okay, so COPD is a chronic obstructive pulmonary disease. It's a condition where the airways in the lungs become blocked. So this makes it harder for the patients to breathe. It's mostly caused by smoking, but it can be caused by other things like long-term exposures from pollution and fumes at work. So a patient may feel on a day-to-day basis that they have difficulty with simple activities like walking up the stairs or carrying their groceries or even getting dressed sometimes. Some of my patients even say taking a bath is a hassle. So they can also have a chronic cough, which produces a lot of mucus and phlegm, which makes it difficult to do the regular activities as well as sleep at night. COPD is also a long-term condition, but with the right care and help, they can be able to manage and cope with it and have an active life.
Wow. So who is most at risk for developing COPD and what should patients watch out for?
So mainly the most common patients I see with COPD are smokers. They're the highest risk of developing COPD. Just keep in mind, not all smokers do get COPD, but most people do have a predisposition genetically if they do smoke for a long period of time. People that are also exposed to high doses, I would say, of secondhand smoke. So if a wife is around her husband for 20, 40 years, if you have these long-term marriages, they are exposed as well. And then those that were exposed in the work environment. Now, probably in the early 2000s, we started to stop smoking indoors, right? So that has created a more clean working environment and less exposure in the workplace. I remember probably when I was a child, people used to smoke on the airplanes, right? They used to smoke in the hospital. So we've come a long, long way. Yeah. So, but with these same things, the same symptoms of mucus and difficulty breathing, with minimal activity, these are early signs of COPD. And that's when a person should probably seek care if they have that history.
Mm-hmm. How is COPD diagnosed, and what should patients expect during the testing process?
So COPD is diagnosed through a test called spirometry. So just because you smoke and you probably may have COPD, to actually be diagnosed properly, you should have the functional test. So this tells us how severe your lung function is impaired. Now, what does that involve? It usually involves breathing into a device. Some machines are more technical than others, but it's breathing into the device, actually blowing out as hard and fast as you can to see how well your lungs are actually working. Now, it can also be diagnosed or suggested on imaging, such as a chest x-ray, if the lungs are hyperinflated, or if you have changes on a CAT scan that suggests emphysema. But keeping in mind, to actually know the function of your lungs, you have to have spirometry.
Wow, I've actually had to have spirometry as well, but I have asthma.
Yes, yes.
One of my relatives was diagnosed with emphysema, and just when I would go to visit him, I would call it the endless cough.
Oh, yeah.
The cough that just kept going out.
Yes.
When is he going to inhale again?
Exactly, because when you have COPD, like just to break it down from a physiological standpoint, it's a problem not with inhalation, it's a problem with exhalation. So you can take a huge breath in, but getting it out is the problem, because when your lungs are damaged, it's kind of like a big box in a room. If you have holes all in the house, then trying to get all that air back into that one passageway takes a longer time. So that's basically what emphysema does. It destroys all the passageways, and then trying to get it back into that small canal, which would be a trachea, your windpipe, takes a longer time. So they can blow out, but it's forever. Yes.
And we'd all just be there holding our breath.
Yes.
Waiting for the inhalation.
Exactly. It's perfect. You described it perfectly.
I call it the endless cough. I watched him struggle. He never complained, but boy, oh boy.
Yes, yes.
Yeah. What is asthma COPD overlap syndrome, or ACOS, and how does it affect treatment?
Yeah. So in Bermuda, we have a high prevalence of asthma. And sometimes it can be confused with COPD. So asthma is reversible obstruction, whereas COPD is irreversible obstruction. So asthmatics can have obstructed lungs and have that endless cough you just described, or a difficulty exhaling. Okay. Now, in terms of COPD, asthma overlap syndrome, patients can have a combination. So a patient that has smoked, that has asthma, probably difficult to do, but some people do it. They can have the biomarkers. We would say we check their blood, and those things that cause allergies and things for an asthmatic patient, they also have high levels as well in the COPD patient. So sometimes I check blood eosinophils or some different type of levels to say, okay, this would guide my treatment in a different way.
Wow. What other conditions could be mistaken for COPD, and why is it important to get the right diagnosis?
It's very important to get the right diagnosis. So some patients have never smoked, but they have the lungs that look like COPD. So I might have a little old lady that comes and says, I've never smoked, and her husband didn't smoke either, but she has these huge lungs, right? And then she's coughing up these copious amount of sputum, right? That condition is called bronchiectasis. So they might have had infections in childhood, or maybe COVID, which is recent, right? And it's caused permanent scarring in the lungs, and the lungs are permanently dilated, or the airways are permanently dilated open, not due to the same pathway as COPD, but they're still open, which causes them to have increased infections and increased exacerbations. So this would, the treatment would be different because it involves pulmonary toileting, which is basically teaching you how to cough up all the sputum so that you don't have recurrent infections. The other thing is interstitial lung disease. That's another disease where, I have a lot of patients that have autoimmune diseases and the lungs become stiffened, or patients that have occupational diseases, the lungs become more stiff. So again, that's when the spirometry or the full pulmonary function test, would differentiate between the diseases. And then there's another one that affects the younger people. So you might have a young person below age 40, because usually COPD is a long-term disease that's affected people over the age of 40. But the people like maybe in the 20s or 30s that have COPD, and it's real COPD, but it's due to a deficiency, genetic deficiency called anti-alpha-1 trypsin deficiency. So it's a genetic condition that predisposes patients to COPD in non-smokers. So that's something that, you also have to look at.
So can you just briefly repeat what other conditions can be mistaken for COPD?
Yes, so number one is the bronchiectasis.
Yeah.
Okay, so that's maybe the woman that has never smoked, but has hyperinflated lungs on chest x-ray, or you might see air trapping on a CT chest, and she's coughing up copious amounts of mucus or sputum. Then the other one would be interstitial lung disease. Okay, so you might have changes on a CAT scan due to constant coughing. But this can be due to underlying conditions like autoimmune diseases, or it can be due to smoking as well, or occupational exposures. And the last one would be antitrypsin deficiency, and that is a genetic condition that predisposes patients to COPD. The genetic testing needs to be done because obviously your eyebrows would raise if a young person presents with lungs that look like COPD.
How do flare-ups or exacerbations affect your COPD, and how can you prevent them?
So flare-ups usually are caused by infections. The cold is a little bit chilly today. My nose is running a little bit. So sometimes just that little bit of a weather change and things can highly affect patients that have lung problems, particularly those with COPD. Air pollution, Bermuda is pretty good, but people complain about our environment, Balco, and people burning trash and things like that. But or even other occupational exposures as well. Again, the constant exposure makes it difficult over time, and this is what can cause the exacerbations. Now, to prevent these, I would say vaccinations, right? And I always recommend it. And I say, Dr. Foley, I'm not getting a vaccination. Okay, but that's my job to recommend. Yeah. Why do I recommend? Because people with COPD and other lung diseases, they already have a decreased function. And with each exacerbation, the lung function declines, right? And it's difficult to get back to that baseline. Wow. So, and then when the lung function is further decreased, it's more or predisposes you to have another exacerbation, right? Yes. So then you have this downward spiral. Yeah. So, and then the other thing that I would recommend is that, to follow up the treatment plan. So if you have inhalers, to use them and then know how to use them properly. I find that in my practice, a lot of patients don't even know how to use their inhalers properly. I'll just tell you, I call it like a long joke. There's a medication called Spiriva. And when it first came out, it used to be in a pill form. And people used to crush it, right? And I remember one of my, old professors saying, the patient came in and said, "No, I'm still breathing. I can't breathe properly." And said, "How are you taking your medication?" They swallowed it. So they didn't inhale it at all. So it all has to go with teaching, Yes. If you don't know how to use your medication and it's in a different type of form, then you can't use it properly. But now we have different mechanisms. Some people with severe lung disease, they have more aerosolized, inhalers. And then, if you use it with the spacers, it can also help with the increased deposition into the lung. And those that actually have really impaired lungs, they may benefit from a nebulizer.
All of the above I tick off for my asthma, unfortunately.
Yes.
But thanks for that. Is there a connection between COPD and lung cancer, and how can patients lower their risk if there is a connection?
Yes, most definitely. I'm not sure if people, correlate it, but people that actually have COPD have an increased risk of developing lung cancer, and it's almost up to 4 to 6 times more likely, because obviously the lungs can be in a state of inflammation, right? Both conditions are strongly linked to smoking, which damages the lungs over time. But yes, again, the chronic inflammation in the lungs from COPD plays a role in the development of the cancers. So the most important things that patients can do, and what I recommend to my patients, stop smoking, right? Easier said than done. I know it's an addiction. It's a habit as well. So, but this not only lowers your risk of developing COPD or the progression of COPD, but also decreases the risk of getting and cancer. So, and the other thing I need to mention is those that do smoke should get the regular lung cancer screenings, because if you do smoke, some people choose not to quit, or those that have smoked and then quit, but then it's up to 20 years of, you have to have exposure for about 20 years. And some people forget that they smoked for 20 years because they smoked in the youth. Now they're 60, 70, and they say, oh, I smoked a long time ago. But they too should be getting the annual lung cancer screening with a low-dose CT scan. And just to put it in there quickly, it starts at age 50 and goes all the way to age 80. So if you have a 20-pack year history, they just decreased the guidelines from 55 years old, so they expanded it to 50 years old to catch more patients and earlier screening. So 50 to age 80, that's 30 years of cancer screening for 20 years of smoking.
But that's great.
It is great.
I love that
recommendation. So if you catch it early, I have some patients that catch it, it's a small growing nodule. You can get a lung resection, or some people just choose to have radiation, and then that's cure. Because a lot of lung cancers go undetected, and when you actually cough, it's too late.
So you've talked a bit about smoking. Is there any difference in who might develop COPD, whether they smoke cigarettes versus, say, marijuana? Hookahs.
Yes. So I say anything that burns can probably cause COPD, right? You have people that smoke crack cocaine or heroin that I saw, in the States. I don't really see it that much here. But yes, they do or can develop COPD because over a long period of time, it's the damage of the chemicals. So yes, marijuana smokers, I find, do have increased lung volumes, and I recently spoke in another podcast. So when you smoke marijuana, some people smoke, it requires a stronger pull, I would say. So cigarette smokers, they do a small puff in and out. Whereas to have the efficacy or, I guess, what the pleasure of smoking marijuana is an increased pull. So you smoke it in and hold. So it's a breath hold.
A deeper breath.
Yes. So you fill up your lungs, and that's what gives you the effects in the brain, and then you let it out. So over that period of time, with those bigger breath holes, you have that hot air in the lungs that's rising. So what I find when I look at patients, they have their CT scans, usually called for shortness of breath, and they have these big bulla, which are big, I guess, kind of cysts or holes in the lung. Interestingly enough, some of the younger people, although they have all of this lung damage, the lung function is fine. But over time, it will decrease because obviously that air gets trapped, and then that's what it's difficult to pull back through the pipe, as you talked about your uncle, was it? Yeah, over time. Yeah.
Wow. And I'm still kind of just stuck a little bit on marijuana. I've since which learned that there's a new type. So
different types.
The one that has that strong, unpleasant odor compared to the old marijuana that I would smell at a football game back in the day. Are you seeing any effects from this newer type of marijuana? Or is it too soon?
No, I mean, just recently I saw, 2 younger people that they didn't come in with COPD per se, but they did have what we call pneumomediastinum. So they took too much of a breath hole, and it kind of, the air seeped into their chest cavity outside of their lungs, right? So, why it happened, I don't know. But they both, said that they were smoking marijuana and not just mixing it with tobacco, because Bermudians, they try to chase it. I call it chasing their marijuana to make it last longer. But some of the young guys, they're using herbs, they said, some rosemary and thyme and real herbs, I had to laugh a little bit, interesting enough, because I'm going to take you back. I had some older patients, probably 1930s. They said they used to smoke cedar bark. Cedar bark is like the bark off the cedar tree, and it used to have some hallucinogen effect. So, yeah, people smoke anything. And it could cause COPD if you smoke it long enough. But, yes, anything that can alter the brain, But, yeah, I guess if you're altered, you can probably hold your marijuana breaths longer. And with that, yeah, you could have COPD.
And so vaping could be a part of this whole smoking.
Oh, yeah, vaping as well.
Behavior.
But that's a whole different conversation, because,
Yes.
that has the chemical toxicity that can cause not only, I wouldn't say emphysema, but it can cause inflammation of the lungs, That's more stuff that I see in the ICU, right?
We might have to invite you back for vaping.
Yes.
Where the conversation is increasing around that
Of course.
topic.
Yeah, especially young people.
Yes. So what are the most important steps you can take to manage your COPD and stay healthy, other than stop smoking anything?
Yeah, so what I would say is, for those that have been diagnosed with COPD, number one, having regular checkups with your doctor. I mean, just because you have the diagnosis, some people can function and some people can't, depending on the severity. Managing, obviously, I said, using your inhalers, living a healthy lifestyle, eating properly. The other things I can say, getting the vaccinations. Exercise, even if it's for a few minutes, if you can, muster up the energy to do it. Yeah, so, and staying stress-free if you can, because people don't realize how much stress affects you when you can't breathe. And panic attacks and all of that go along with it, yeah.
So you may know that we talk about health topics from A to Z, and I would say, without a doubt, every health condition that we've discussed and shared with the public, one of the main recommendations has been to develop a healthy lifestyle. So if we all were able to be more consistent with that, we could help to either prevent most diseases, many or most, or lower the severity,
Right. Yeah, most definitely. I mean, healthy lifestyle encompasses so many things, right? So, I mean, yeah, you have people that are running and things like that. I mean, or I would say you're super healthy, and then regular healthy. So it all depends with diet and things like that, and then the predisposition. I mean, some people still eat a healthy lifestyle and exercise, and still come down with stuff, right?
Yes.
It's genetic as well.
Yeah.
So not only is it environmental, but also genetic as well.
Yeah.
So.
Yeah, thanks for adding that part. Genetics are very important.
Yes.
Do vaccines help to protect you from infections that worsen COPD? So you did mention vaccinations earlier.
Yes.
So can you expand on that a bit?
Yeah, so there's vaccinations that I particularly recommend for my patients. There's the pneumococcal vaccine. It basically protects against almost 25 strands of pneumonia. I think before COVID, people didn't, I can't really say that, but I think COVID kind of heightened our awareness of how severe, respiratory illnesses can be. Pneumonias have been around and taken lots of lives for centuries, right? But, according to guidelines, at the age of 65, it's recommended that patients get the pneumococcal vaccine, which lasts for 10 years. Now, if you have, or you are an immunocompromised patient, then you will get it at a younger age, depending on what your disease is. But it's recommended at 65 for the pneumococcal vaccination. The other one I recommend to my patient is it's a new one. It's called the RSV vaccination. Usually, patients I see have severe infections to this. It's usually seen in young children, infants, causes copious amounts of secretions, and they can't cough them out, which ends up leading to respiratory failure and sometimes death. Now, if you can't cough out secretions and you have COPD, all of that mucus, then obviously it leads to respiratory failure and death. The other thing is the influenza vaccine, which is an annual vaccine. I recommend that for my patients as well. Because again, if you get sick from any of these, your lung function decreases. And if you constantly have that spiral, you can't function over time.
Yeah.
It may not be an immediate death. I say it's more like a suffering, to the end. It's horrible to watch over time. People gasping for their last breath. It's awful.
Yeah, I've been around a family member who, not nice.
Yeah.
Not nice. How does oxygen therapy help people with COPD, and when do patients typically need oxygen therapy?
So again, as your function declines due to repeat infections or continuous smoking, and the decline in lung function, I would call it the diffusion, which is the passageway of oxygen across the membranes to get through the lungs back into the bloodstream, that decreases. Okay, so let's look at it like if you're taking a walk down Front Street. I'm trying to do the Front Street mile. A young child would run really fast, but a person with COPD, it's not that they can't run fast with their legs. It's just that when they take their breath, it's going to take a longer time for that oxygen to catch up for those legs to move, right? So that's what causes the oxygen levels to decrease. So oxygen supplementation is there to maintain optimal oxygen levels, and I would say above 88% for a patient with COPD. And usually it's for 15 hours or more, the recommended guidelines.
15 hours a week or a day?
A day.
Okay.
For those that need oxygen. Now, some patients don't need oxygen all the time. I have some patients that only desaturate with exercise, okay? So when they're sitting and not doing anything in a sedentary way, they're sitting and doing okay. But as soon as they get up and walk or try to do those activities, bathing and getting dressed, they desaturate. So for some of my patients, I just say use the oxygen with exertion. But patients, again, non-compliant, they only like to use oxygen when they feel like they're about to pass out, right? And then they put it on. So, if you need to go grocery shopping, put it on. But again, it comes with this stigma that, but I always say they're going to see you on the floor at Marketplace if you don't use your oxygen. So you must just put it on. Put on your mask and no one will know the difference.
And the oxygen tanks are so cute now.
I don't know about cute, but they do have backpacks.
They're not as clunky. Yes.
And they're not as cumbersome, but they can be heavy for somebody that's already, they might have a little bit of weakness. So,
That's what I meant by cute. I've seen people carrying the oxygen tank.
Yes.
And wheeling it along with their wheelchair.
Oh, yeah, it's a lot. Yeah.
So they have the packs now, and I'm like, okay, well, thank goodness there's a better solution so people can have a better quality of life.
Yes. So in terms of like mortality benefit, the two main things that for increased mortality benefit with COPD are stopping smoking and oxygen.
Wow.
So inhalers don't really prolong life, which, it's more
for that moment.
Yeah, exactly.
Yeah. So would you say that the establishment of a healthy lifestyle is really what can make living with COPD easier, or are there other behaviors people can explore and adopt?
In terms of adopting other behaviors, I think for a COPD patient, it's allowing them to have their best life with what they have. Okay. So I recommend pulmonary rehabilitation. That's doing exercises and trying to maybe use oxygen with exercising so that their muscles don't atrophy or weaken any further. It's also incorporating a diet, so maybe you might want to have a dietitian to optimize what we call your muscle metabolism. That's mainly because when we can't breathe, we can't eat if you can't breathe. If you ever sat and watched somebody, like you said, maybe your uncle, it's choosing between eating and breathing, because obviously you need oxygen to digest your food.
Yes.
So it's one or the other. And if you've noticed, some severe patients or family members with COPD, they're quite frail, and I would call it cachectic, which is basically their muscles are wasting away,
Yes.
because over time the COPD eats away at the body. So again, not only does it's incorporating a healthy lifestyle, but at that point it's just optimizing what you have with other healthcare providers like the dietitian, rehab, physio, because all of these come into play. And also people forget COPD is very highly linked to depression. I know mental health is, we're talking about mental health this month, or or I don't know what month we're in, but maybe last month.
Yeah.
But yeah, it's a big deal, and it's often forgotten. If you can't breathe, you can't live, like really live.
Exactly.
And that's, I have some patients that I just want to get up and go, but I can't. And how depressing is that when you want to, but you can't do it?
Quality of life. I keep coming back to that during these fantastic interviews, What are some key facts about COPD that every patient should know? So any advice you have for people, any important information?
So, again, stop smoking. That's one of the main things. The other thing is, I would say, to avoid, toxic environments. Not like family toxic environment, but that too, because that's stress. But like healthy environments, keeping your environment in your home clean. There's a lot of mold here in Bermuda, and although it can, exacerbate asthma, if people have that ACOS, the ASCOS, or asthma COPD overlap, it can exacerbate that too. Yes. Also, having the homes dehumidified. I know it's starting to get wet and rainy. Yes. All of that, those weather changes can exacerbate things as well. So, I mean, it's the healthy environment and keeping things clean in the house. Because most patients that with COPD are sedentary, so they stay a lot in the home. So, yeah.
Yeah. And I've seen sometimes as some of our seniors age, even if they're aging healthier, that cleaning isn't quite a priority as much. It's just what, it happens.
It does.
They're not dirty people.
No, it just happens.
It's just not a priority any longer.
Yeah, so I mean, I can't say that whether dust in and of itself exacerbates COPD, because usually it's linked to infections in terms of respiratory infections. Yeah. But again, if those people do have a predisposition, an allergy or, things like that, it can probably exacerbate their symptoms. Having a stuffy nose due to an allergy and you can't breathe out of your lungs, I'm sure it's going to cause you a problem, right?
I would think. Dr. Foley, I want to thank you for coming to talk to me and our listeners about breathing easier, understanding, and managing COPD. Thank you so much for coming.
Thank you. Anytime. So glad to be here.
Thank you. And I extend a huge thank you to our listeners for tuning in. Keep an eye on this spot for the next episode of Health-Abets. Please leave any comments or feedback on the Department of Health YouTube page and follow us on Facebook at Department of Health. Stay healthy, Bermuda.
You have been listening to Bermuda Health-Abets. Please note, anything you heard on this podcast is not a substitute for visiting your healthcare provider. If you have a topic or want a question answered, please contact the Health Promotion and Wellness Office of the Department of Health by emailing healthpromotion@gov.bm or by calling 278-4900. Be sure to listen out for the next episode of Bermuda Health-Abets.